recorded.
Welcome, everybody. We're delighted to have you here to join us for our airway clearance therapy webinar. We know that this is an important part of PCD care, and we are delighted to have guest speakers who will introduce themselves as the slide presentation moves on, who are experts in this area and can be providing some information for you. And then at the end of the discussion, we will leave time for questions. So please save all your questions. If you wish during the presentations, you can put them in Q&A, and we'll get to the questions at the end of the presentations. So I think just because this is a pretty full presentation, we'll just go ahead and get started. And I'm going to start by introducing Dr. Melanie Collins, who will be kind of running the slideshow for us. Dr. Collins is from Connecticut Children's and is a pediatric pulmonologist and the PCD Center Director at Connecticut Children's Hospital. Dr. Collins?
Good morning, or afternoon, actually. I'm Mel Collins. As Michelle mentioned, I'm from Connecticut Children's, and I'd like to turn the webinar over to Catherine Saunders, our first speaker.
Hi, everyone. I'm Dr. Catherine Sanders. I'm a pediatric pulmonologist at McLean Children's Hospital in Texas. In my previous position, I was a PCD Center Director. I'm brand new to Texas, so if any of my Memphis folks are on, hello, and I miss you. So today we're going to talk about various aspects of airway clearance, something that many of you are familiar with probably, but may want to learn a little bit more about the why and the how. So to start, our first part, we're going to talk about some of the basics of what the airways are and how mucociliary clearance functions. Next, please. So to start, I want to look at the very basics of what the airways are. So at the top of that figure, you can see what the vocal cord area or the larynx. If you go just below that, you come into the trachea or the windpipe, and that's the main airway. It then branches into the left and right side, as you can see, and branches into smaller and smaller airways or bronchi, into what we call bronchioles or very small airways until next it reaches these little air sacs that comprise the lung. These are called alveoli. This is where what we call gas exchange happens. So that means bringing oxygen into the bloodstream and getting rid of carbon dioxide from the bloodstream. And that's a really important function to pretty much any part of your body. You need to take in oxygen for the body to function. We need to release carbon dioxide, which is a byproduct of a lot of the functioning of our body. Next slide. So something that's kind of unique to the respiratory system that's a little bit different than a lot of our body systems is it's open to the outside world. So as we're breathing in air to take in oxygen, we're also breathing in dust and dirt and other particles next, and air pollution next, and also various infectious organisms such as bacteria and viruses. So all of these things are coming in as we're taking in oxygen. Next slide. Go back one more. What we don't want is for all of this junk that we're breathing in to get out into the alveoli. If that happens, it can block that taking in of oxygen and releasing of carbon dioxide. And since that's so essential, we want to protect those alveoli and make sure we're not allowing any of this stuff to get down in there. Now, next slide. So if we zoom in next and look at the airways, this is a close-up of the lining of the airways. And what you see are these nice pink cells. Those are called the epithelial cells. And that just means the cells that are the lining of the airway. And that's where the cilia are. So at the top of those cells are the cilia. Most of you are pretty familiar with cilia, the little hair-like structures that sit on the top of these cells. And they're in this nice thin liquid layer. So they're allowed to move back and forth in a really nice way so they can sweep. And they move in a coordinated fashion, sort of like they're doing the wave. On top of those cilia are a thin layer of mucus. So as you breathe in all those particles and different things from the environment, it's trapped in that mucus. And then the cilia brush it away. They brush it up to the top of your airway and it's swallowed. You don't even notice. And this is happening constantly. Next. So this is an image or a video showing normal ciliary movement. So you can see how they're moving in a nice coordinated fashion. And you can even see there's a little particle there that's moving. And so this is constantly happening and people aren't even aware of it. Next slide. So what this is called is the mucociliary escalator. And so you can think of it, our airways making mucus, moving it up the escalator, and this is happening constantly. So the airways act as a self-cleaning machine. And this is what happens when it's functioning properly. Next slide. So then what happens when the escalator is out of service? And people who have PCD, we know those cilia don't function as they should. And so the mucus is not swept up as it needs to be. Next slide. So we'll talk a little bit more about cilia. We talk a lot, we call them, hair-like structures a lot, but if you zoom in, we can actually see they're really complicated structures. And you don't need to know specifics of this, but this is just to show that cilia are actually made up of many hundreds of different proteins. And in people who have PCD, one or more of these proteins isn't formed correctly or doesn't function correctly. So those cilia aren't able to move and sweep the mucus like they need to. Next. So this first video here is in a person who has mutations in the DNA H5 gene. And many of you may have heard of that as the gene that you have that's affected. It's the most common. And you can see as that movie plays, there's a little bit of movement of those cilia, but not much. They're just sort of quivering a little bit. Next. This next video is somebody who has a DYX1C1 gene mutation, which is less common. And again, you can see just a little bit of quivering of those cilia, but you're not getting the full sweeping motion that's coordinated. So that essentially is the escalator not moving that mucus as it needs to. Next slide. So what happens when you don't get normal movement of that ciliary escalator is mucus starts to build up. It's normal to produce mucus, but if it's not being swept away, you get buildup of the mucus, and those breathing tubes, the airways, actually get plugged up with mucus. Next. As we said, we breathe in lots of different bacteria and viruses. If the mucus that is trapping them is not being swept away, those infections begin to grow and multiply. So you get invasion of that mucus with lots of bacteria. Next. When you get all these bacteria and viruses, then you start getting activation of the immune system. And I'm going to talk in a minute about inflammation in PCD because I think it's a really important thing to understand. But essentially, when you have these infections coming in, you get activation of the immune system. And that in turn causes more mucus, more infection. Next. And so we sometimes will visualize this as a cycle, but it's actually more of what people describe as a vicious vortex, where all of these factors are making the other factors worse. And then you get over here in green, it says airway structural damage. Some of you may have heard the term bronchiectasis. And what that means is that the walls of the airway are actually damaged. And so they don't function normally. So it's like having a rubber band that's been stretched out that then doesn't work normally. So the airways themselves get damaged, and that makes everything worse. So you get in this cycle that's really difficult to break. Next slide. So I want to talk for a moment about inflammation. And this may be something you hear more about in the future. So this nice diagram here is from a new review paper from Dr. De Jesus Rojas and colleagues. So what you see over here on the left side of the picture is healthy airway. So the cells look nice and pink. You have the cilia on the top and a small layer of mucus on the top. In people who have PCD, as you move over to the right, you'll see that the mucus starts to build up. And then you get the infection, as we talked about. So those little green cylinders and pink small dots are infections and bacteria. Those start to grow and multiply in that mucus. They love that nice, warm, moist environment. And then you get activation of the immune system. So those pink and gray blobs that you see are various cells of the immune system. And they get the signal that there's infection there that needs to be cleared. And so they come in. You can see that one pink cell is sort of bursting open like a piñata and releasing things. So these cells actually release different chemicals trying to actually fight off the bacteria. But what happens, if you look below at the red cells underneath, those chemicals are actually harmful to the airway cells themselves. So they get red and inflamed, and those cilia actually get stripped away. You start to produce more mucus, and all of this is what we would refer to as inflammation. This whole process of the cells coming in, releasing these chemicals to try to get rid of the infection, but actually doing harm to the airway cells themselves. Now, when somebody typically gets an infection, you have activation of the immune system, and this happens temporarily where the cells come in, they kill the illness, but then it goes away. The problem in PCD is that this happens chronically. So the airway cells never have time to return to the normal healthy cells on the left side. And so they're chronically inflamed like this. Next. And there's been studies looking at airway inflammation in people who have PCD. And they can actually measure some of those substances that are released by cells of the immune system. And people who have higher levels of inflammation who have PCD have lower lung function. Next. They have more bronchiectasis, that damage to the airways, and more plugging up of their airways seen on CT scan. Next. So all of this means that mucus clearance gets even more difficult because there's more mucus, because there's more of these inflammatory cells. All of that makes it harder for this mucus to move. So inflammation in the airways is a really big problem in people who have PCD. And so be on the lookout for, this is possibly a target for medications. If we can calm down that immune response, can we make symptoms better in PCD? Next slide. So as we mentioned, we kind of get in this vicious vortex of all of these things happening in the airways that make each other worse. Next. So one system that we have that's our natural backup system for moving mucus when the normal mucociliary clearance is not enough is cough. And I always stress with anybody who has PCD that cough is really important. So people who have PCD are going to cough every day, and they need to cough every day. And I think one of the most important things that somebody who's newly diagnosed with PCD or their child's newly diagnosed with PCD is understanding what that person's baseline amount of cough is. Next. So cough should be encouraged. We don't want to tell people not to cough. Our goal is never to stop cough completely. Now, that being said, if somebody with PCD does have cough that's much above their normal baseline, they may need antibiotics or more airway clearance or something to help clear it. But we never want to try to suppress cough or stop the cough completely. Next. We don't want to use any sort of cough suppressant medications because we don't want to stop our natural drive to cough when needed. Next. When somebody is doing treatments in airway clearance, they should actively be coughing and huff coughing, which we'll talk about a little bit later, to try to move the mucus out. And kids with PCD often learn to cough up and spit out mucus pretty early on, which is a good thing to do to be able to help move the mucus along. Next. And we do understand that coughing is sometimes disruptive or can be embarrassing. Nobody loves to be the person who's coughing all the time. So I also always stress that people with PCD should have special allowances at school and work. So kids should have a 504 plan for school, and adults who work should also have some accommodations in place. So if they need to excuse themselves to the restroom to cough up some mucus, or they need to have tissues at their desk, or whatever accommodations they may need, it's important to do that so that people with PCD can feel like they're able to cough when they need to. Next. That being said, cough is really important. Cough should be encouraged, but coughing alone is not enough. So when we look at the sputum or mucus of people with PCD, it's been noted to be more abundant. So we know that it builds up over time. So they're going to have more mucus than average that they're going to need to bring up. Next. It's thicker than typical mucus. So usually the mucus that's produced is nice and thin and easy to move, but in people who have PCD, it tends to be thicker. Next. And it's more difficult to move with just cough alone. So people may be able to cough up some, but there may be some that's so thick and that it's difficult to cough up. Next. And there have been research studies that show that the mucus in people with PCD can be just as thick and difficult to move as the mucus in somebody who has CF. So we often hear about mucus in CF being really thick and sticky, but the same can actually be true in PCD. Next. And that's where your airway clearance regimen comes in. So we need the cough to get some of the mucus out, but we also need to augment that with some medications and devices that will help move the mucus out most effectively. So with that, I'm going to turn things over to Dr. Collins.
Thank you. All right. So my talk is trying to be a convincing talk on airway clearance based on what we have in the literature, and really taking a look at yourself and seeing what's going to work for you. And I did this based on Fleetwood Mac titles, and I assume most people on this call might be too young to know who Fleetwood Mac is. So I did include a picture of them from the Rumors album. So for as many decades as people with PCD have been tortured with time-consuming and complex airway clearance regimens, researchers have examined mucociliary clearance. And one of the first studies in 1990 really looked at how fast does mucus move from the central airway. So once it's in the right place to be coughed out, and they looked at 3 different patient groups. One had bronchiectasis and did not have PCD. Another group had PCD, and a third group had no lung disease at all. And they found that the speed of the mucus movement was really dependent on how fast your cilia beat, which is not necessarily something we can change right now. There's always new research to be done. And the mucus load, so how thick or heavy the mucus sitting on your breathing tubes is. And this is definitely something we can change. So in order to really kind of think about how mucus works, I thought we could do a quick comparison between a common condiment and get our brains in gear. So ketchup is the condiment of choice. You may ask why I selected ketchup. Ketchup and mucus are both non-Newtonian fluids, which means when you apply certain forces, they flow or they become thinner. This also means that the fluid can be removed from the surface of the lung or the ketchup bottle. This is called the wettable surface, by creating a shear force, which moves the mucus. For the lung, this is the airway surface layer above the cilia. Now, while airway clearance may be new to some of you, I expect that banging ketchup out of a bottle may not be. So we'll keep the comparisons going, and we'll see how a lifetime of ketchup extraction has prepared you to do airway clearance in PCD. So our goal for ketchup is to put it onto the plate or onto your meal. And our goal for mucus is to get the excess mucus, not all the mucus, but the excess mucus out of the lung. So for ketchup, you're going to open the cap. If you're a pulmonologist, you may insert a knife to make sure air gets behind ketchup because you know the principles of moving fluids. For mucus, you have to open your breathing tubes, and this can actually be done 2 different ways. It can be done with medications, or it can be done with an exercise regimen, but a vigorous exercise regimen, not like 10 minutes of Wii tennis. Then you have to mobilize the fluid. So for ketchup, you're going to shake or bang on the bottom. But for mucus, you can't exactly shake a person with the same vigorousness that you can do a bottle of ketchup. So we need to mobilize it, and we can use oscillation or we can use shaking. And you can do that through an airway clearance device or by banging, thwacking on the chest to do postural drainage and percussion. The goal is that you're going to make this fluid less thick and less viscous. And then the very last thing you need to do is transport the ketchup or the mucus out of the area. And we do that by huffing. Then at the very end, when you cough, you create a shear force, and that moves the mucus totally off the surface of the airway and out of your mouth or into your esophagus, where it can be swallowed, depending on your personal preference. Now, when I started this talk, I had dreams of finding the perfect articles to show you how important scientifically airway clearance is for people with PCD. And unfortunately, those were dreams. And the reality is a little bit more of a piece of modern artwork where we have to use some creativity to use the literature to guide our individual care. So here's a quick guide that I thought would be helpful for people with PCD to sort of evaluate studies and determine if they work for them. So the first question you always want to ask yourself is, who are the people in the study? Do they have PCD? Are they like me in terms of gender, lung function, and exacerbations? It can be really difficult to show something's beneficial or statistically significant in really well or really sick patients. The other question is this a long-term study or a short-term study? So a study might not show a difference in a therapy with a single visit or over a 3-month period. But if something is continued long-term, the therapy may show maintenance of health versus decline over time. And those studies are missing. And was there a quality of life component to the study? So science and statistics are great, but the real question is, how does this make people feel? And is there a significant risk to the technique in the study? So if the risk is minimal, it might be something that you want to try and incorporate into something new. I would just pause for a moment here to say, thinking about things over the long term, thinking about the lack of available studies on airway clearance, this is really one of the key reasons why it's important for patients with PCD to participate in registries, because then we're able to sort of conglomerate the data and find trends in what works over a longer term period of time. So the first study we're going to talk about, the question was, can we use evidence from the airway clearance literature from CF to help people with PCD? And it looked at a variety of different papers. And so one of the conclusions they came to was exercise is beneficial due to physiological and psychological benefits, and it can cause bronchodilation, but exercise alone is not enough. The active cycle breathing technique, which we'll hear a little bit about later, is reasonable to consider for mucus mobilization. PCD cilia in Petri dishes, so not in someone's body, but in the laboratory where we can kind of look at them, they show increased movement in response to mechanical stimulation like oscillatory devices. So might be worth a try. And the optimal position is unclear for performance of airway clearance. And this is really important because a lot of our positional studies are from the CF literature, but lung disease in CF and PCD is not the same. So one thing you might ask your healthcare team is to consider your CT scan and your clinical exam findings when they're recommending positioning for your airway clearance. And a key finding, which is not new, is that pulmozyme may increase exacerbations in bronchiectasis and could cause a faster rate of lung function decline. So I think, as everybody on this call already knows, CF is not PCD, so we just have to interpret literature with caution. The next paper looked at, are device-supported airway clearance techniques better at improving lung function and quality of life? And this is also a new study that was just released in September from Puerto Rican Journal of Health. They looked at a total of 54 patients by combining 2 papers They had originally found 389 papers, but when they looked closer, they weren't really looking at PCD. In the paper, the patients were 6 to 20 years of age, and they were all in their baseline health. In the 2 papers they used, it was a crossover trial design, which means that the patient tries one thing and then switches over to something else to look for a change. In the first study, they used high-frequency chest wall oscillation, which is commonly referred to in the US as vest therapy, compared with chest physiotherapy, and this was in a hospital setting with a trained physiotherapist for 5 days. The other study used an oscillating PEP device and compared that with chest physical therapy at home for 3 months. When they looked at all of the studies, they said that there aren't enough studies to answer this question. But again, if we look at this in our registry and everyone participates, we might be able to answer it. The second thing is that they did find that it was safe to switch over and try something new. So you might want to consider trying a new therapy and seeing if it benefits you. The next study by Vanderwoot and colleagues was looking at lung function parameters. And so their question was, does airway clearance therapy provide a short-term benefit to lung function? In this study, patients performed breathing tests, including spirometry, and MBW, and LCI. All the patients were at the baseline level of health and their baseline level of lung function. They then received airway clearance therapy, which was PEP, huff cough, and manual compression, or as I like to think of it, 30 minutes in heaven, with a trained respiratory therapist. Then they repeated their breathing tests, and there was no improvement in breathing tests right after airway clearance. So the take-home message is that at a baseline level of health, a last-minute session of airway clearance session on the way to the clinic is unlikely to improve your breathing tests. But I wouldn't take home to say that this means that airway clearance doesn't work, because they were really looking at it in a short amount of time. So there's no single magical study to really demonstrate what's best for airway clearance. And it's best to use a variety of methods because, like our moods, our mucus can vary from day to day. So you need to show yourself some grace and flexibility while you sort of seek consistency rather than striving for perfection. And then that's going to maximize your airway clearance. So the key considerations that you want to think about is, how am I feeling today? Am I at my baseline health? Is there something a little off, or am I sick? How much do I have to give today? Am I short on time? Can I just do something quick? Just do something so that I've at least cleaned a little bit out. Am I exhausted? Do I need something that's like minimal effort and maximal benefit, or extra time? I have extra time this morning. I could just invest a little bit more. Did the therapy you select work? Do you feel amazing after? Do you still feel like something's left, but you already finished airway clearance? You're just going to check that box off. Or do you feel like this therapy really didn't do anything at all? And if that's the case, you really need to ask yourself, did I need to add 5 minutes? Do I need a different technique? Am I having an exacerbation? And maybe I need to reach out to my team and say, hey, this isn't working for me. As teams, we really want to hear from our patients and families about what works and what doesn't, and don't just stop something at home. And then the last question is, does this regimen work for me? Is it just right? Timing, everything is great. I have the flexibility I need. Or is it not right at all? It's not working on my mucus, and it's really like making my mental health decline. Because I think one thing that I didn't talk about at all is just how much time all of these therapies take. So when you're thinking about therapies for a rare lung disease like primary ciliary dyskinesia, it gets really difficult and overwhelming to find evidence. And we have practices like airway clearance that are standard to care. And so it would be unethical to do a true efficacy trial and withhold care. But I would encourage you to find the balance between the science of your cilia and the science of yourself, and think about what science is saying, but then also you really want to think about how you or your child feel, and teaching yourself and your child how to listen to their body and view airway clearance as a dynamic and interactive process where you can use different tools for different days to help maximize health. And with that, I'm going to turn it over to Michael, who's got all the tips and tricks for doing it.
Thanks, Dr. Collins. So it's an honor to be here. I'm Michael Davis. I'm an associate professor here at Riley Hospital for Children at Indiana University and all the adult hospitals there. And so I'm a clinician scientist. My clinical license, I'm a respiratory therapist who here in the States do a lot of the airway clearance teaching. And then I did my doctorate in lung physiology and the physics of how the airways move all these secretions around. What I'm going to talk to you about today sort of builds on the amazing talks given by Dr. Sanders and Dr. Collins. So Dr. Sanders talked about how our airways normally clear themselves and that mucociliary escalator. And then Dr. Collins talked about the importance of airway clearance and the evidence for using it in primary ciliary dyskinesia. And I'm going to talk about the ways that we try to clear the airways when they can't clear themselves, like in PCD, when airway clearance and the mucociliary escalator is broken. Next. What is airway clearance therapy? And so in short, it's the therapies we use to help clear the airways when they can't clear themselves, either at all or as well as we would like them to. You can break that into three categories of therapies. We have therapies that are intended to help us move secretions around, that mucus in the lungs. And so these are things to just help get stuff moving, which are what your cilia normally do. And then we have therapies to help get them out, either to, again, just help the cilia move the secretions out like they normally would, or to help you more effectively cough them out. So again, either get stuff moving and rattling around or get it out, or both. And then the other therapies we have are there to try and minimize those complications that Dr. Sanders talked about that happen when we don't clear our secretions. If they stay down there, we end up with areas of the lungs that can collapse and we can get pneumonias. And so we have therapies that attempt to address those. Next. So there's two big categories we can break down our airway clearance techniques into. Pharmacologic, which just means where we use drugs to help clear the airways, or non-pharmacologic, which is where we don't use drugs, we use techniques. And so for the pharmacologic ones, we use those drugs either to change the properties of the mucus that's down in your airways and make it easier to clear, or to change the airways of the patient themselves in order to make just the airways easier or more open or larger to get those secretions up and out. And, with the techniques, again, it's not drugs, but we use different techniques that we either have the patient use themselves, or we have practitioners or family members or friends use on patients to, again, help get those secretions loose, moving around, up and out. Next. And so here is a table of an example of the different drugs that are often used for airway clearance and the four big categories that we think of them as. And so on the left, we have beta agonists, which are just bronchodilators that help open up the airways and keep them open and give them tone. So the theory behind using these for airway clearance is that if you can get the airways nice and open, it's easier to cough stuff out of them. And so things like albuterol, which is one of the most common asthma medications used here in the US, would be an example of something that in theory should help with airway clearance. The second column there, the anticholinergics, those not only can help open the airways up, but they also dry out the airways. And so in theory can change the way the mucus is moving around by that. We then have these mucoactive drugs, which are just what they sound like. They're drugs that actually target the mucus as opposed to targeting your airways. They target the mucus that's in them or the patient's airways. And these can be drugs that help break down mucus or different types of mucus. They can help make it thicker, which in theory might make it easier to cough up if it dries up into a ball. They can help make it thinner on the idea that if it's thinner, your cilia can sweep it around easier. They can really target any different part of the physics that make your mucus or our mucus the consistency that it is. We even have drugs that we inhale that just make it, that draw fluid into it to try and make it, again, easier to get up and get out. And then we have a few novel therapies that target different aspects, both of the mucus and of your airways or our airways to help get them up and out. And that's what's listed under those novel therapies. Next. And then again, the non-pharmacologic airway clearance techniques, which are most of what we're going to talk about here, and were covered, many of these were covered by Dr. Collins. We have listed here, and I'll go into more specific details on them in a little bit, but just to list them off, we have forms that are as simple as just changing your breathing technique. And so using either just simple different breathing techniques or directed or huff coughs, in which they just help us get those secretions up and out. Chest physiotherapy, which is arguably the oldest form of ACT, in which we literally from outside of the chest wall thump on our patients and try to both rattle those secretions loose and also in theory get them up and out where it's easier to cough them out. And then we have different devices that can either alter the way that secretions move around in your airway through your breathing pattern or through actually putting different pressures on your airways. Next. So again, Dr. Collins gave a much more thorough overview of this, but it's just worth repeating, even though I gave a whole slide on the drugs that in theory should work with airway clearance. We have almost no evidence for any of these in the PCD setting. It doesn't mean that they aren't changing the consistency of your mucus or of your airways, but just doing those things doesn't necessarily mean that it's going to help get those secretions out and make a difference. But that said, in general, all of the techniques for airway clearance in PCD are at least one of them for every patient is routinely recommended, and I'll go through those in a minute. Next. Another one worth talking about, and there have been several papers that came out this year talking about this, is exercise, which I include in the category of airway clearance techniques for airway clearance therapies. And there is some controversy over this because there's all different types of exercise. Some exercises in different environments can have different effects on different people's airways. But in general, every study that has looked at whether or not patients benefit from exercise, we can't say that exercise is better or should replace other airway clearance techniques that I'm going to talk about. But in general, exercise is recommended, and all of the studies that have looked at patients who exercise with PCD have seen positive effects. Next. So for the rest of this, I'm going to talk about some of the most common types of airway clearance techniques and therapies, and just sort of an overview of how they work, the theory behind why they should help your, clear your airways, and just, again, not full details on how to use all of them, but sort of the basics on them. Next. So I mentioned a few slides ago that the oldest form of ACT is chest physiotherapy. And another version you'll hear of this called is postural drainage and percussion. You'll hear those reversed as well, percussion and postural drainage. But they are just what they sound like, that we can, knowing how your anatomy works, we can lay the body in different positions that effectively encourage the draining just by simple gravity of different regions of your lungs down back towards your trachea and your throat where it's easier to cough them out. And then once we put a patient in that position, we can percuss or thump on the chest wall over those different regions and try to, again, shake those secretions loose while draining them down into the bigger airways that make it easier to cough out or cough up and swallow. Again, the theory behind this is simply just to loosen and clear secretions from the 5 lung lobes. When I was in respiratory therapy school, we actually had to know the postural positions to drain every lung segment, which was my hardest test, and I have no recollection of that. But a neat thing that I will brag about here in the pictures here that was designed and sort of invented here at Riley Hospital for Children, where I work, are these onesies that are available that are now distributed by a maker of the vest, which I'm going to talk about soon. Unfortunately, they're only useful for small children that can wear this onesie. They actually identify the different sections and the order in which it's recommended to do percussion therapy. And they come with a diagram that also demonstrate postural drainage. You can do this with a naked cupped hand, just in order to get that optimal thump. They also make devices that are soft cups that in theory make it easy. But one of the things about this therapy is that it takes a long time. That in theory, you should be spending several minutes over each lung segment. And we have multiple segments within each lobe. And so you can see how this is exhausting both for the person who has to do it to the patient and also the patient. But it's effective, and that's why we've been doing it for over 40 years. Next. So the next category of devices I'm going to talk about are these expiratory pressure devices. And so again, these are actually help shake secretions loose in the airways through giving resistance while you breathe out. And so there are some of these that don't oscillate. On an earlier slide, I showed one called a PEP device, and that just gives back pressure that helps pop those airways open and in theory make it easier to get secretions out. About 30 years ago, somebody thought to add in a valve that shakes. So you are both breathing against a valve, sort of like if you were to stick a straw into water and try to blow bubbles in it, you're going to get back pressure. But then also that valve oscillates or shakes either by a ball bearing or a turbine. There's a lot of different ways to do this. And so you get a combination of that back pressure that helps pop open your airways and also this shaking that in theory both rattles secretions loose and also aids what ciliary function you might have into bringing those secretions up. And then afterwards, those secretions should be loose enough that you can cough them up and out. Three of the common brands, and I am not affiliated with any brand, so I'm not going to endorse any of them over one another, but you'll see the flutter valve out there, which is on the bottom left, the acapella, which is the bottom middle, and the aerobica or aerobica, which is on the bottom right. And what is also convenient with this is if you do require inhaled medications or prescribed inhaled medications, the acapella and the aerobica you can do in line with your nebulized treatments. The next device I'll talk about here is IPV, intrapulmonary percussive ventilation. So this is a large device. It's not as portable and handheld as those PEP devices and oscillatory PEP devices I just talked about. But a way you can think about this is that it's effectively a gas compressor. And so it blows gas in through a mouthpiece while you're inhaling that helps, again, open up those airways and those alveoli like we want to help get those secretions out. But then it also percusses. And so if you look down at the middle picture there, you can kind of see this waveform, this block coming up. And the big block is you breathing in and getting this wave of pressure. And then it'll shake that wave while it's in there. Again, with that theory of trying to both loosen secretions and also aid in those secretions coming out. This is often used inpatient in hospitals. It's not very commonly used at home. But there are mask adapters, mouthpiece adapters. You can use this in conjunction with a tracheostomy. You can plug in all of your inhaled medications or oxygen therapy with it. Again, more commonly seen in the inpatient setting. And two of those devices are the MetaNeb and the Valera. The Valera is designed for home use, but still often you will see it in inpatient settings. Next. A device that really revolutionized airway clearance in the cystic fibrosis population well, the technology is called high frequency chest wall oscillation, frequently referred to as the VEST in the States. The VEST is a brand name of a device, but you'll hear it used for the generic devices as well made by other companies. And so this, as opposed to blowing a gas in or having you exhale against a valve, this literally shakes from the outside of your chest wall to help loosen those secretions and direct them towards the middle airways. And so you put this vest on, it plugs into either a device. There is one that is self-contained that doesn't plug into a device, and it actually shakes. It squeezes you tight, which is a pressure that you set. And then it shakes at a set frequency or number of shakes per minute. And you set that for a fixed amount of time. And all you have to do is stand or sit, and you will get some airway clearance. But an important thing to talk about here, this is another one that's controversial. Some countries actually specifically won't use any of the VEST therapies for airway clearance right now. because there have been some studies that did not show it to be as effective as just manual chest PT or those oscillatory exhalation devices I talked about. Most of this is presumed to be because of poor usage of this. If you don't put the vest on tight enough, if you don't set your settings properly, it's not a magic device, right? You have to use it correctly. And perhaps the most important thing is that you need to be sitting in a position that helps make sure that your airways are expanded and are ready to let those secretions come up. So if you just put it on and lay down or slouch down and it's up over your shoulders, it's just because it's on wiggling doesn't mean that it's necessarily doing its job. And so usually when we initiate this therapy, you have a training session with an airway clearance expert, either a respiratory therapist, physical therapist, or physician or nurse. But again, we often at our center will have patients come in, and if their lung function is declining after they get a vest, we might even switch them to something else to see if they actually respond to a different device better. Next. And then arguably the most basic form of airway clearance is the huff cough. It's very difficult to use this in extremely young patients because it does require coordination and they have to be able to understand commands. But it's just, again, it's a specific type of cough that helps very effectively move mucus from the smaller airways to the larger airways and get out. It's great to pair this with the other devices we've already talked about. So you do your airway clearance therapy, whichever device it is, and then during your interim breaks, you use a huff cough to try and get those secretions out that your techniques might have loosened up and moved where you want to be. There are great videos of this online if you look up huff cough technique. But in short, you sit upright, make sure your posture is nice and great. You take almost a full breath, but not quite a full breath. You hold it for a few seconds. And again, based on the same principles of all the things we're talking about, it's about getting your lungs open and getting secretions loose, right? So you hold your breath for a couple of seconds, which helps ensure those airways are open. And then you exhale in an explosive manner, but not a short manner. So you don't just and done. You want to do this explosive exhalation and keep it going as long as you can. And that both helps with the explosion to help get those secretions loose, but also by continuing to blow it out, you carry them from the lower airways up to the bigger airways and out. And you typically repeat this a few times. So with that, I'll just wrap up with a few points. Again, it's really an honor to be here. I really love working with our On the Move programs. These are the things that are really moving all of the airway clearance forward, I think. Next slide. I think as Dr. Collins and Dr. Sanders said before, a big thing we need here is we need collaboration, because trying to generate the evidence requires a lot of centers doing things in a coordinated way, and it requires a large number of patients, and that's just hard to do. A lot of the most recent data for airway clearance is coming out of the United Kingdom, largely because they have a unified network within one country, and it just makes it easier. And so getting involved with the PCD Foundation and the center is really helpful here. What I'm going to plug here is the IPCD-PN, which is the International PCD Physiotherapy Network that was created 2 years ago. It is specifically dedicated in its charter to generating and finding the evidence for best physiotherapy practices for PCD. Everyone is welcome. It's based in the UK, but they have webinars frequently. Next slide. I think what I'll conclude with is to say that airway clearance is integral to PCD management, even though we don't necessarily have the best practices. I think everyone can agree that airway clearance in general is important. We especially lack evidence for airway clearance pharmacologic therapies. Many centers still keep extrapolating from the CF community, which is, comes with some problems. And to quote my friend Connie Webster, who's one of the founding members of the International PCD Physiotherapy Network, further research within PCD using PCD-specific outcome measures is needed to provide evidence for the most effective physiotherapy treatment techniques in PCD. And with that, I think we can pass it. I will put in one more plug, November 29th, which is unfortunately a big holiday here in the States. But the Beat PCD network, which is largely in Europe, is hosting a webinar specifically on airway clearance, and it'll be demonstrating airway clearance from the perspectives of different countries and who's doing what. That will also be open to the public. And please contact us if you want information on how to log on to that.
My name is oh. My name is Ashley Barber. I'm a registered nurse, and I am the PCD Center Coordinator at Connecticut Children's Medical Center. I'm here to talk about cleaning and disinfecting airway clearance devices that they all just talked about. So the big question is how often we should be cleaning and disinfecting our devices. It's recommended to clean and disinfect after every use, which we know is a large ask. So we ask if you're unable to disinfect after every use, to at least clean after every use, and you can disinfect daily. If you are sick, we recommend to really try to clean and disinfect after every use. That is very important. Next slide. So I wanted to start off with nebulizer supplies. As some airway clearance devices have nebulizer supplies in line you can do with them. So cleaning, we always want to clean before we disinfect any of our devices. And the first step for both cleaning and disinfecting is always to wash our hands thoroughly first. So cleaning nebulizer supplies, you're going to wash the cup, mouthpiece, and mask with warm soapy water. Do not use antimicrobial soap or white liquid dish soap because it can leave residual and damaged nebulizer parts. Rinse with distilled water and place on paper towel to air dry. We do recommend a clean paper towel rather than a dish rag, as the dish rags can collect bacteria as well. Disinfecting with boiling water is one way to disinfect the nebulizer supplies. So you can bring the pot of water to a boil. Then we want to turn off the water and submerge the separated nebulizer parts in the boiling water for 5 minutes. And do not boil the face mask. Just wash, rinse, and air dry the face mask. Remove from water and place on a paper towel. And once thoroughly air dried, pieces can be stored appropriately. Next slide. And you can disinfect with isopropyl alcohol or 3% hydrogen peroxide. So you would do this by placing the separated nebulizer parts in flat containers or any container, but we just find that flat containers work best as you don't need as much liquid to submerge. So you would submerge in the 70% isopropyl alcohol or rubbing alcohol for 5 minutes or hydrogen peroxide for 30 minutes. We just have to be mindful of those time differences. I know they're together, but 5 minutes for the alcohol and 3 minutes for the 30 minutes for the hydrogen peroxide. After they are disinfected, we want to make sure we rinse in sterile water after they're submerged in the alcohol or hydrogen peroxide. And you can do this by purchasing sterile water or by boiling for 5 minutes. And we would then place all the pieces separately on a dry, clean paper towel. Nebulizer supplies can also be disinfected in the dishwasher, but only if the dishwasher is greater than 158 degrees Fahrenheit. And you can do this by placing the parts in a dishwasher basket on the top rack and for 30 minutes. Next slide. Nebulizer supplies, after they're clean and disinfected, you can store in a clean container with the lid once completely dried. Replace your peri-nebulizer mask and cup every 6 months, and we don't want to wash the tubing. We just replace that every 6 months, and disposable nebulizers must be thrown away after 24 hours. Next slide. First is for airway clearance devices is the Aerobica, which I do have one here to clean. We want to press down on the tabs on either side of the device. We would remove the valve, cartridge, and the mouthpiece so that we have 4 separate parts. You're not going to disassemble any part of this valve cartridge. This is just going to maintain as it is. And you're going to soak in warm soapy water for 15 minutes and just agitate gently, move it around, and then you want to rinse in warm distilled water. You're going to shake out any excess of the water and place on a paper towel to dry vertically. For the aerobica, it's very important to make sure all of the water is out. And you can also place it in the dishwasher in the basket on the top rack after you remove all the pieces. And then reassemble the device, but make sure it's thoroughly dried before reassembling. Next. So the aerobica can be disinfected by boiling, the same way you would boil your nebulizer parts, bringing it water to a boil, removing it from the heat, and placing it and letting it sit for 5 minutes, and then placing it on a towel to air dry. You can also disinfect the aerobica in a microwave steam bag, and you would do this by following the manufacturer instructions on the steam cleaning bag. And then you would just remove from the bag, allow to cool and air dry, and reassemble once thoroughly dry. Next. And again, you can disinfect the aerobica in the isopropyl alcohol or hydrogen peroxide. You would do this the same way you would do the nebulizer parts, placing in alcohol for 5 minutes or hydrogen peroxide for 30, rinsing in sterile water after, either by purchasing sterile water or boiling for 5 minutes, allowing to air dry and reassemble. Next. So next we have the acapella. So for the acapella, you're going to remove the mouthpiece. These sides you can gently squeeze to lift up and then pull it back to come remove the top. And then you're going to remove the white piece, which is the rocker, from the middle. And then you have, again, 4 separated parts. And you're going to do the cleaning the same way you would do the aerobica, just placing in warm soapy water and agitating gently, and then rinsing in distilled water and allowing to air dry before thoroughly reassembling. And with the aerobica, the acapella, we definitely want to make sure it's dry before reassembling. We have seen rust on this metal part here, so you just want to make sure that it's dry before you reassemble. So boiling, the same way you would boil the nebulizer in the acapella, you're going to bring it to a boil, remove from the heat, and then place them, and then allow it to dry. The acapella can be placed in the dishwasher as well. Make sure it's in a basket on the top shelf. And autoclaving, if you have accessibility to an autoclaving, it can withstand temperatures not to exceed 277 degrees Fahrenheit. Next slide. And then again, it can be disinfected in the isopropyl alcohol or hydrogen peroxide, the same way you would do with the others. Just make sure you're doing 5 minutes for the isopropyl alcohol and 30 minutes for the hydrogen peroxide. Next slide. The acapella cannot be disinfected in a microwave steam bag, and you should not use bleach to clean as well. The acapella DH also should not be put in the dishwasher or boiled, just disinfected with the isopropyl alcohol and hydrogen peroxide. So just ensure you know which device you have before disinfecting. Next slide. The PEP device. So you're going to disassemble the PEP device. The white tubing and the pressure manometer cone, you do not wash, you just soak the mouthpiece or rinse, clean the mouthpiece. And then so you would do that in warm soapy water and allow all pieces to air dry. And the PEP device can be disinfected in the isopropyl alcohol and hydrogen peroxide like you would do the others. Next slide. So the flutter, you're gonna start by unscrewing the perforated cover, and then there's a stainless steel ball inside and the cone that's underneath the ball. So you will have 4 pieces of the flutter as well. You're going to do the same thing by soaking all of the 4 pieces for 15 minutes in soapy water, and then making sure you shake out all the excess water before you place on a paper towel to dry, and then reassemble once completely dry. Disinfecting, the flutter should be boiled. So the same way you would do the other airway clearance devices, by bringing the pot to a boil, remove from the heat, and then place the disassembled parts into the water for 5 minutes, and then remove and let air dry thoroughly before reassembling. So now the vest. So the vest, in order to clean, we want to open up. So this is about the Hill-Rom vest. I know there's different kinds of vests that have either Velcro or buckles. So this is mainly about the Hill-Rom vest. So open up the buckles and lay the garment flat on the table. You're going to open the zipper at the bottom of the garment and unfasten the snaps that secure the bladder to the outer garment. You're going to remove the 2 hose connections from the outer garment and remove the bladder from the outer garment. So you're not going to wash the bladder, you're only going to wash the outer garment. That's fine. And you can machine wash only the outer piece as follows. You're going to then refasten all the buckles and zippers and make sure the shoulder straps are connected. Machine wash or hand wash in cold cycle only, and non-chlorine bleach may be used as necessary. You're going to hang dry or tumble dry on lowest temperature, and if needed, you can use a cool iron setting on this outer piece. Like I said before, do not machine wash or dry the bladder. Next slide. The Afflo vest should only be disinfected with broad spectrum disinfecting wipes or sprays. It should not be machine washed, use bleach or iron, or tumble dried. You can wipe down the tubing again with a broad spectrum disinfecting wipe and ensure both the bladder and the outer garment are thoroughly dry before reassembling. You do not need to clean after every treatment. You can just clean the vest when visibly soiled. And then lastly is the IPV cleaning. So this goes over how to disassemble the phasotron. So you want to gently rotate, and there's a good diagram on the side that has better pictures to go along with it. But you're going to gently rotate the nebulizer bowl towards the rear of the phasotron until it stops, and then separate the nebulizer from the phasotron. Holding the nebulizer cup, twist the nebulizer bowl to remove the bowl from cap, and twist white cap on the rear of the phasotron to remove the cap, and gently sliding the venturi with spring from the phasotron body. Right. And then once you have all of those disassembled, you're gonna rinse all the parts except for the tubing harness and filter under warm water for approximately 10 seconds before you soak in warm soapy water. And then after you soak in warm soapy water, you're gonna rinse all the parts thoroughly in sterile water and shake out excess water and allow to air dry before reassembling. And then lastly, just disinfecting the IPV. You would do that in the isopropyl alcohol or hydrogen peroxide, the same way you would do the others, soaking for 5 minutes in the isopropyl alcohol or 30 minutes in hydrogen peroxide. Make sure that they're submerged fully, rinse in sterile water, either purchased or made by boiling, and allowing to air dry and reassemble once thoroughly dry. And with that being said, I believe we're on to questions.
Yes, I think we're on to questions. Thank you to all of our speakers. We do have a nice list of questions here that we'll try to get through. If possible, I'll try to kind of group together the ones that are similar so that we're not answering the same thing over and over. There are several questions related to Pulmozyme or the use of mucolytics, why they're not routinely prescribed in PCD and whether they should be, and specifically questions about Pulmozyme and is it a problem in PCD? So I don't know, maybe Dr. Collins, you want to take a shot at that one?
You're still muted. Yep.
Sure, I would be happy to take a crack at that. So I think I will confess that I am a Pulmozyme lover, but I don't use Pulmozyme for PCD. And I will also confess that when the guideline came out that you can't use Pulmozyme in bronchiectasis, was a little horrified because I have one really severe bronchiectasis patient who does not have PCD, who really had a life-changing difference once she started using Pulmozyme. So everyone is an individual, and I would really encourage you to discuss with your care team regarding your own personal use of Pulmozyme, because our bodies are not all created equally. But in general, we do not recommend the use of Pulmozyme in PCD because of that risk factor for increased complications or exacerbations and lung function decline. I think hypertonic saline is also a mucolytic that people ask about because it was really it's talked about a lot in the CF literature. And as an individual in the CF literature, even when we're on inpatient services, we think a lot about using Pulmozyme to kind of clear thicker secretions. There was actually one study that did show that patients who had PCD, they did have on one quality of life score, which is a bronchiectasis quality of life score, and not the St. George's respiratory questionnaire, that they really did show a significant improvement in their quality of life on hypertonic saline. And so that really speaks to what Michael was saying, is that we really have to do PCD directed research using metrics like a PCD quality of life score to see what is the benefit in the patient. But I just want to pause for a moment, because all of the trials and things that we talk about, they have, they're looking at large groups of patients, and we are really concerned with that one individual patient sitting in the room in front of us, whether you're a parent or whether you're looking in the mirror of yourself. So we really encourage people to talk directly to your healthcare team and share your concerns and consider what medications you're doing or what medications you might want to try. And if you want to try something new or you want to stop something, do like your own trial in yourself, where you're looking at objective measures like your pulmonary function, like how much cough you're having, how much exacerbations. And I would also say this is a tricky time of year to do that, because in the winter, people tend to be sicker. So maybe in the spring.
So I just want to say two things just as general comments about pretty much everything related to PCD. Absence of evidence is not evidence of absence. So just because we don't have the solid evidence that something works, it doesn't mean it doesn't work. It just means the evidence has not been collected yet. And a lot of that has to do with, it's very difficult to get good evidence in rare diseases. We just don't have the patients, even globally, to do some of these big studies that would need to be done. The other thing about like the Pulmozyme study is that it was done in non-CF bronchiectasis. That means all causes of non-CF bronchiectasis, not just PCD. And so the study had negative outcomes in that large group, but in terms of what it did for PCD patients, we don't know. They weren't looked at as a subgroup. So just be careful about applying globally standards from evidence that's not very strong. And if it's working for you, and that's the case by case thing that we're talking about, then it's working, and kind of leave it at that. Okay. Now we have some questions.
Well, I think Dr. Davis might have something to add.
Oh yeah, I appreciated that point, Michelle. I was just going to add, and I thought that that Dr. Collins did a great job of this on her everywhere slide, I believe. But that you're absolutely right that the lack of evidence shouldn't necessarily show that something doesn't work. That said, you know, there are some procedures that are pretty clearly more benign than others, and treatments that are more benign than others. And so that I do think is where it gets tricky is, you know, again, even though you're absolutely right about that, the non-CF bronchiectasis trial, you do have a medication that, you know, does have documented untoward effects, even in patients that benefit from it. And so I think it's easy to say with some things, like most airway clearance techniques have, you know, either a flawless or a nearly flawless safety profile in their past. But with medications, that's not always the case. And I do think that again, like you'll probably hear us say a lot, is this is more of the case by case evaluation would be my 2 cents. But
one thing that we often, patients will ask if they should be taking something, and of course that's something to decide with their physician, but I think one good first question to ask yourself is it helping? If it's not, talk to your physician about it, because maybe it's not the right thing for you. Dr. Davis, a lot of these I think are probably for you, or for Dr. Collins too, with regards to the study showing no short-term benefit to lung function during baseline health. Does this suggest that maybe it's not helpful to be done unless you're sick?
Oh,
Uh,
no, the short term was like within clinic.
Yeah.
So it was saying like, I went to clinic, I was having a normal day, I did a little airway clearance. And I will tell you, I've done that in clinic. I've been like, oh, let's do a little airway clearance and see if we could get even better lung function 15 minutes later. I think what it's actually telling us is that doing something one time and thinking that you're going to change the 3 months that came before it is probably really not going to happen. And I also think you really can't just do airway clearance during sickness because you have PCD when you have health. So you have to do a little bit more every day because you are like the picture that Dr. Sanders showed. You're always going to have more mucus with someone else than someone else. So you really need to kind of help your body clean out all of that mucus by doing a little bit more airway clearance. I don't know, Mike, Dr. Davis, you were going to say something.
Oh, no, I was just going to add that the other thing that study, a big takeaway from that beyond the importance that it's not a short-term one-time thing, was also to guide clinical trials for PCD in the future to say it's okay if people are doing airway clearance. It's not going to alter their lung function results in a way that'll confuse the study that day, which with a lot of our interventions, we have to think of timing with regards to what is it going to do to the other data that we get.
So don't withhold airway clearance for study participation. Okay, so if combining drugs and techniques, when should albuterol, or I would assume any bronchodilator, be used? Before the technique? During?
I always recommend opening the breathing tubes first. So if you use albuterol, or if actually you can also use exercise, right? There was a great study by Dr. Bush that showed that in PCD, so a PCD specific study, if you really did kind of a nice exercise test, you can bronchodilate your airways just as much as you do with medication. So for folks who like to take a more holistic approach, you have that option, but albuterol first. The way I think about the approach to medications and clearance is you want to take your albuterol first and open your breathing tubes. Then if you're using any sort of like mucus busting things like hypertonic saline, I'll say pulmozyme to be fair, and mucomest, then you kind of want to do those with your airway clearance technique. I think that's one of the beauty things of the aerobica is you can kind of do, or a cappella, you can do 2 for 1. And then you want to use your huff cough at the end. And I feel like now I've cleaned my breathing tubes. And at that point, that's when I want to do my inhaled antibiotic. Or if you also have asthma, that's when you want to take your inhaled steroid. So you want to kind of have minimized and cleared off that mucus before you kind of put those soothing things on the surface of your lung.
Dr. Davis, what's the evidence for ACBT?
I'm going to have to look up that acronym.
I'm assuming it means
It's
airway
that
clearance.
active cycle thing.
Oh. So I will say I don't know of any evidence for that is specific to PCD. That we do have evidence, again, because this is a fairly dated technique. So there are studies from the 80s and 90s just showing that it can effectively clear secretions when, and it's been used as a marker of how well treatments work. Are you able to get more through your active cycle of breathing technique, and huff cough, again, including with that, is known to be a more effective way to clear secretions than other cough techniques. But I can't tell you anything that says this is superior for PCD. I wish I could.
Okay, I think this is an important question. Dr. Sanders is not here anymore, but she showed 2 different PCD genes, and the question is, should mucociliary clearance be different for different genes?
No, I think it's great to think about personalized medicine. And again, as we continue to do more and more research, it would be great to have super personalized medicine and say that, wow, you do the aerobica if you have this gene, and you do the acapella if you have that gene. But I think the problem is that we're really complex human beings. So we have more than just our PCD genes. We have genes that regulate our inflammatory responses. We have genes that regulate our response to infection. So for me personally, you have to look at yourself as an individual. And while your genes are part of it, they really aren't the be all end all for how you should approach your therapy. So if you have a really severe disease, a gene that's typed as severe, it doesn't mean that you need to do more airway clearance than someone with another disease, another gene rather. So no, not yet.
Dr. Davis, 2 questions about the best use, what age is recommended and how tight should it be? And should the tightness be determined prior to or after pressurization?
Yeah, so again, the repeated caveat, age use, I don't have a specific age use for patients with PCD. In our setting, we use it with whatever age is large enough to fit in a vest. I don't know if there's an actual cutoff. Dr. Collins, do you know of
No, it's usually
yeah,
size.
it's size, right? But that in general, so sorry, the first question was age. What was there a second part to
The
that?
tightness.
Tightness.
Yeah, how tight?
So the thing that's tricky is that there are different vest devices, as I mentioned, and each of them have slightly different actual vests that you put on and slightly different settings. And so you really need to follow the insert with that. We have what most places follow, which was designed for CF, is the Minnesota protocol. But again, even within that, you have to figure out which type of vest. We have sleeve type vests. We have those with shoulders, and it varies. So the short answer is that you want the highest pressure that the patient will tolerate and be comfortable with. But if you're able to get a formal fitted vest and a nice snug seal, the Minnesota protocol says that you start with a pressure of 6 and work that up until the patient is uncomfortable. The max on that device is 10, and then step down once they're not comfortable. As far as tightness, we use the 2-finger test just like we do with other fitted devices. If you don't want it so tight that you can't get 2 fingers in, because just like with anything, too tight is bad and can cause skin breakdown and things like that. But you want it nice and snug with a good seal that's comfortable, is my short answer.
I think too, you have to take a developmental approach. So a lot of times when kids become toddlers, parents start thinking about the vest. I usually like parents at that point to also consider one of the oscillating PEP devices, aerobica, acapella, while they can do the neb at the same time. Because I think sometimes in the United States, Dr. Davis really tried to point out that in order to effectively use the vest, it has to be a very active process. So maybe they're not an amazing aerobica user while they're using the vest, but really trying to make the vest be more interactive, even though they're small.
So I used to work for one of the vest companies in a past life, and the reason that they limit it to size of the chest is because chest wall compliance in very small kids can make them hyperventilate. So it's a safety thing. That's why there's not vests for really tiny people, although it can be used, certain types of it in the newborn period, if needed, being watched very carefully.
Yeah, with a band.
Yeah.
I would say too, I think it's tricky because a lot of times when you have a toddler and you're having another baby, you really need an extra set of hands. So the vest is very helpful to use as an airway clearance device. But I would also add that there's nothing superior about a mechanical device over the chest physiotherapy, right? We don't have evidence for that. So I don't want people to feel like they have to go out and buy something expensive or highly technical to really deliver effective chest physical therapy or postural drainage and percussion.
Dr. Collins, we have a couple of questions here. I'm really glad this is coming up. It's related to inflammation and allergies in PCD. Can you explain the type of inflammation that we're talking about in the airway versus the type that you would see maybe in allergic or asthma kinds of things?
Yeah, so it's tricky, right? Because when we think of inflammation, there's all different types of chemical mediators that cause that. And in allergy, most people with allergy tend to kind of move towards one side of the spectrum, where things like antihistamines or a lot of people with asthma, that kind of side of the spectrum is in inhaled steroids. But the inflammation solely related to PCD is different, right? Those cells that Dr. Sanders showed with her slides, those are more immune cells. And so using things like antihistamines and inhaled corticosteroids wouldn't really be beneficial or effective unless you had asthma or traditional, the chemical we talk about is IgE mediated allergy. And to demonstrate those things, you really should have specific testing, because the last thing you want to do is end up on a bunch of ineffective medications.
Okay, and we're going to move into lots of questions about cleaning, Ashley, and a request for your slides. So we will make this whole presentation available after this, but you clearly touched on things very important to people. We do have one sterilization question for Dr. Davis. Knowing the increased risk of NTM, is this an area of importance to discuss when it comes to not only cleaning but sterilization techniques?
Again, I'm going to defer to Ashley, who did a very thorough cover of this. But the short answer, yes, I'm always worried about NTM, and I'm sure Dr. Collins is as well. But yeah.
And that's the drying piece. That's really, really critical. And I, you know, in one of our labs, we're thinking about drying. Like, please don't go buy things to dry. But I would say when you're drying, have things in an area where they're drying away from collections of water near your sink, away from areas that people are prepping food, and away from, you know, just your kind of general family. So, well, no offense to your families. But just the drying is really the key piece, and making sure that things, as Ashley mentioned, are thoroughly dry, and then making sure that you're replacing things when they should be replaced. And if there's everything we were talking about is plastic. So if you're getting like cracks or really bad scratches, then those things need to be replaced a little bit sooner.
I'm going to try to bunch things together here because we're running out of time. But actually, we have a question about disinfecting in an oven at 175 Fahrenheit for 20 minutes. Then a question about if distilled and sterile water are interchangeable, since they were both mentioned. And can we get your information in a document after the webinar?
I don't have a document, but I'm more than happy to make one. The oven question, I did not see anything. I've never seen anything about disinfecting in the oven. So I personally would not recommend. I've seen the boiling and the all the ones I went over today, but I've never seen anything about the oven. And then the slide, and then distilled versus sterile water. So distilled water is basically just boiling the water for the 5 minutes to make, or boiling water for 5 minutes to make it distilled. When it comes to disinfecting, either or were recommended. Either you could buy the sterile water or boil the water so that it was distilled, and either one of those would be okay.
Okay, a question. Can we use a baby bottle sterilizer? And then also a question about humidifiers, not airway clearance devices, but will sterilizing those with rubbing alcohol disinfect them?
For the humidifier, I definitely would read up on the manufacturer of the humidifier, just because I'm not completely sure on what, I'm sure they all have different recommendations for disinfecting. And the baby bottle sterilizers, I have seen that be done in the past, and that is a way that the nebulizer can be sterilized.
We have a couple of questions related to the vest and how often it should be cleaned or washed.
So the vest company says when visibly soiled. I would also recommend to have some kind of routine, not letting it go months without being washed. And so I would definitely recommend at least monthly. or when visibly soiled, and also after illness. I would recommend to wash after illness as well.
I just want to make one comment here because we've had this come up a lot. If you are buying a vest off of eBay, you have no idea who's had what germs that they're coughing on that vest. So first of all, it's a prescription only device, not a great idea to buy it from a third-party seller. But if you're going to do it, be sure you sterilize the whole thing before you use it.
And again, I just want to emphasize, like, the vest is not the be all end all. So if you had a vest before and you love a vest, but I really want to get away from people feeling like they have to be pressured to spend huge sums of money to do effective airway clearance. You know, the oscillating PEP devices are, you know, in the $100 to $200 range. And frequently you can get those through your insurance, through the clinic, and they're just much more affordable, portable, and easier to keep clean.
Okay, a couple for you, Dr. Davis, on N-acetylcysteine, and probably Dr. Collins too. How much to take daily, and should glycine be taken along with it?
You say glycine?
Glycine.
Is this for ingestion or inhalation?
I was gonna say, I mean,
Because I have patients who do both.
There's people taking acetylcysteine orally.
Yeah.
Yeah, I was just saying, for inhaled purposes, I gotta tell you, I'm not a huge fan of N-acetylcysteine in any setting other than burn. And the glycine question, I'm curious if the person on the call can say what they're referring to. They're referring to the inhaled glycine that I'm doing clinical trials with, or a different glycine? If so, I'm really honored that you know that I give people inhaled glycine.
So Mike P, if you're still on the line, do you want to just provide a little more background? Okay. GLY-NAC, which is combining glycine and NAC together orally.
Yeah, I've got nothing for you there. I defer to anything Dr. Collins says.
So, well, I think those aren't anything that I have like specific scientific data on, but I know they're praised for their anti-inflammatory properties. I am happy to give the literature a whirl on that. And then Michelle and Lynn can send out an email, because, you know, I actually have a lot of faith in different supplements, but I do think we have to balance that with evidence. So I'll write that down I'll get back to you on it.
Okay, question about using a Wabi UV sort of mini fridge device that is used to dry and UV sterilize devices. Is that acceptable?
So
you can go, Dr. Collins.
that's okay. So you know, I think I did research studies on using steam sterilization, UV sterilization. And what I would say is one of the key things, because all of these devices are plastic and we all want to do the minimal amount of effective airway clearance that we can, is that you really want to follow the manufacturer's guidelines for cleaning and disinfection. And that's what Ashley presented to you today. So other than the nebulizer used with inhaled as Trianam, there's actually no supporting evidence for using those devices for sterilization, no matter what the baby sterilizer is. And the issue is that you have a baby, you bottle feed for about a year, and then you don't need that device anymore. These devices, you don't know if they've actually reached temperature every time. You have no way ensuring that they actually reach the appropriate temperature to perform sterilization. So that's why we don't really recommend using like a household device like that. We have used UV in the lab, and we didn't see a huge effect on the nebulizers. But as Ashley mentioned, for some of the other devices, there's other pieces of plastic and metal, and they're actually physically moving a lot more. So thinking more about batching things for the day rather than using these other types of devices, it might be more helpful.
Okay, so we are at time, and I want to make sure that our speakers have volunteered their 90 minutes already, and I think we're happy to stay on and keep trying to work on questions. You need to
I'm
leave.
happy to stay on.
Yeah,
Okay.
I'm good for at least, you know, a good stretch more.
Okay. Well,
And
we'll
if
try
folks
to-
think of other questions, by all
Yeah.
means, get my contact info.
Okay, another question about control 3 acceptable as disinfectant. I think that you've
Not anymore.
kind of answered that, use what the manufacturer says to use.
Yeah, and they don't say control 3 anymore, and also vinegar is not acceptable anymore, as well.
For Dr. Davis, a specific type of exercise that would be the most helpful for airway clearance.
I mean, again, the evidence here is really lacking. The only one that I'll give you, because I look a lot at asthma and PCD, we're discovering are really quite quite commonly paired together. I'm not a big fan of swimming in chlorinated pools, but again, if you, as we said, it's all about how you respond. If your favorite exercise is swimming and swimming doesn't make you worse, I do not want you to stop swimming. But when I advise people on exercises, that's one of which I'm always cautious. There's a lot of literature in the asthma community of swimming, causing decreased lung function at least immediately after swimming. So I tend to not encourage that one unless somebody is already doing it and having positive results. But for me, I don't really have any no-nos for exercise. Dr. Collins, you probably know more about this.
Can I ask a quick question
I'm
before
not a
you,
pediatrician.
before you throw it over? The swimming with asthma, have they
Yeah.
looked at the difference between a salt water pool and a chlorinated pool?
I have tried to do that study for 17 years. I used to study the UVA swimming team for asthma purposes. You'd be amazed what their lung functions were. They were not great for D1 athletes. But all to say, what people have looked at is the headspace differences between the saline pools, which still have chlorine, right? They just have
Yeah.
much less.
Yeah.
And you do see less chloramines in the headspace, but I'm not aware of any study that has actually shown a difference in lung function effects between saline and non-saline pools. We were trying to do that, and it was just really hard to control. Also, not every saltwater pool is the same. And so some of those have more, I mean, it just like not every chlorinated pool is the same. Some chlorine pools you go in and your eyes start swelling before you get in the water, right? And some of them you don't. So short answer, Michelle, I would speculate that a saltwater pool is going to be slightly less caustic to the airways than a classically chlorinated pool, but I can't give a scientific answer to that. Sorry.
Okay.
And I think it depends on your own experience, because I have patients whose lung function during swimming season significantly increases. And then when they go back to couch potato time, then I'm all stressed out trying to figure out the lung function, and then swim season starts again. But the problem, like Dr. Davis mentioned, is that if you're having a reaction, then it can be an issue. So I just want to make sure, like, if there's parents on the call, they're not like filling in their pools and saying their kids can never swim. I do think what I learned from the swimming, though, is that if you're picking an activity, you should really try to pick a sustainable activity and a sustainable program, because it does affect your baseline lung function. So you want to do something that you can maintain over time. The studies done by Dr. Bush, they were using a treadmill and they were doing like a classical exercise test. But I don't think that means everyone needs to be trained to a treadmill. It's really about getting the aerobic activity for about 30 minutes a day. And actually, the American Academy of Pediatrics recommends outside activity for children for at least an hour a day. And I haven't really met any children anymore who get that.
I think that it was good that you pointed out aerobic activity is the point. You're trying to get your lungs working. Okay, I just want to answer this question quickly because it's a little bit kind of more related to the PCD Foundation. Plans for geriatric PCDers. The plans that we have right now, we're trying to rapidly expand access to adult PCD centers. Right now, most of this is through adult bronchiectasis centers. And there are a lot of PCDers sitting in adult bronchiectasis centers who don't know they have PCD. So that's what's happening right now. These will be centers of excellence, just like our pediatric centers of excellence are, with multimodal care, lots of different specialists involved. So yeah, if you contact the PCD Foundation, we can probably get you directed to a center close to you or relatively close to you as we keep growing this network.
Michelle, I don't know if they meant like airway clearance plans, because as you age and get older, there are concerns about osteopenia and use of the vest. And also you have to be able to generate like a certain amount of force. I think
Yeah.
Dr. Davis would agree, like when you're older doing the aerobica or the PEP. So I would
Yeah, so
recommend, most hospitals have a great pulmonary function lab. So while they might not be an expert in PCD, they would be an expert in older folks and could really kind of do what we do is called a airway clearance teach, and sort of do a one-on-one and really see like what's most efficacious for you, given the fact that as you age, your body changes and, you know, might not be as straightforward.
Yeah, I think her question was more, should she be moving closer to a facility that has better understanding of PCD with aging? My knee-jerk response would be yes, get close to somebody who knows what they're doing, but I know that's not always reasonable either. So next best is to find a good bronchiectasis clinic that focuses on airway clearance. Bronchiectasis is making tremendous strides. It kind of was an invisible disease for a long time, and all of a sudden it's not. So should be better information and better care in the near future.
Move to Connecticut. We have a great adult PCD center.
Yes, you do. Okay, so a couple of questions on combining corticosteroids and long-acting beta agonists. Is that a good idea? And then kind of somewhat related, we mentioned that pharmacological ACT isn't routinely recommended, but every doctor prescribes salbutamol and hypertonic saline. I'm not sure that that's true. A lot of doctors do, but a lot of doctors at our PCD centers do not routinely prescribe those things. So corticosteroids and long-acting beta agonists, and should patients with PCD be on salbutamol and hypertonic saline?
So I think those are two great questions.
Go for it.
I think so. I really love long-acting bronchodilators and inhaled corticosteroids for asthma. And I really am a strong proponent of using what's called single maintenance and reliever therapy. And if you look at asthma guidelines, they really are suggesting that albuterol is not the way to start with asthma patients anymore, that we should use these medications. So if you look at how quickly the long-acting bronchodilator, and actually, I need to be really specific here, because the only one that is acceptable has formoterol in it. So that's the only long-acting bronchodilator that can be used for rescue in combination with an inhaled steroid. And the unique thing is that the onset of action is similar to albuterol. So it is 10 to 15 minutes, and then it should last about 12 hours. For me, I would envision using this for patients who had more of an asthma picture. And we definitely have patients who have PCD and asthma, right? Like one doesn't protect you from the other. But I would just strongly encourage you to make sure that you know why you're taking the medication. I can't find any study to show that it's safe. And when you think about extrapolating things, I've tried extrapolating the use of the long-acting bronchodilator and ICS for my horse who has asthma, and it did not work. So just be careful when you're using things, maybe not based on evidence. And Michael, did you wanna, I actually don't prescribe a lot of salbutamol. Well, I don't prescribe any, but it's albuterol in the US and hypertonic saline. And the reason that I don't is because I think that time is valuable and precious, and we just tend to pile things onto people sometimes without really thinking, or you may need something because you're sick, but does staying on it every day really prevent things? And now I'm just going to defer to Dr. Davis on the rest, but I'm happy to answer more questions about my lack of hypertonic saline use.
No, I echo everything Dr. Collins just said. In fact, just to add on to the formoterol thing, not to go down an asthma pipeline here, but the new international guidelines for Europe are actually about to abandon albuterol. Not that we are in
As
Europe.
they should.
Yeah. But so the thing that I will say, and this is not currently backed by evidence, I will throw this out there first, but you know, historically, a lot of patients with PCD who have a long road to diagnosis at some point get diagnosed with asthma, either correctly or incorrectly. And often when they then get an ultimate diagnosis of PCD, historically, asthma medications get discontinued. And then what we've seen is often patients then have an asthma attack because they have two diseases, right? And we actually have shown that PCD might actually cause some asthma. And the thing that I would just encourage this audience is that if you do think that you have asthma, or you do think that you were worse after discontinuing asthma meds in light of a PCD diagnosis, don't be afraid to have that discussion with your pulmonologist. And just, you know, be aware that asthma and PCD might actually be a lot more common than we think it is. I, for one, believe that is the case. And there is absolutely no reason to not take asthma medications if you have asthma and PCD. At our center, we now routinely screen our patients who have PCD for asthma as well, rather than sort of wait. But there's no evidence to support that. This is in the sort of the frontier land of PCD. I just think it's important to say that.
So I think it's also important to point out that there is a much larger use of inhaled corticosteroids in the US than there is in any other country when it comes to PCD. And whether that's helping or not is not clear. It's just more of a practice thing. So that's another area that we need to look at because steroids have downsides. So just using them, if they're not helping and you don't need them, all you're getting is the negative effect and not any of the benefits. So that's something that's being looked at closely. I think that this is an important point to make before we get off of here. Someone's asking about, does it have to be distilled or sterile water? Can normal water be used? And I think getting back to the NTM and maybe some of the Pseudomonas questions, we should talk about what's coming out of people's taps. So they know.
Yeah, so it's definitely not recommended to use just normal tap water. We recommend distilled or sterile water for that reason of there's lots of minerals and things coming out of tap water that we just don't know. And we don't want, once your nebulizer and airway clearance devices are sterilized, by putting that just normal tap water on it, it's no longer sterilized.
And
you
I think
can buy like distilled water by the jug. And for the sterile water, I've never ordered through the insurance. I've never ordered big bottles of sterile water for people to wash because families prefer to just get the jug. But I have ordered it for patients with other diseases who are on ventilators. So I'm sure you could order it. I think it's just more of a storage and a convenience thing.
I think a lot of patients don't realize that a lot of the bugs that we worry about in PCD, Pseudomonas, NTM, they are everywhere. They're in your tap water. They're coming out of your drain. So it's not an exposure thing. You're always exposed to them. It's a susceptibility thing, but there wouldn't be a whole lot of point in putting it on devices you're going to then nebulize into your lungs, just in case you have Pseudomonas or have some nasty bug in your tap water. That's why it's recommended not to do that. The same thing for sinus rinses.
And also, it's really the collecting, right? So some people are like, oh, I have a filter on my tap, so then I'm using filtered water. And I think while filtered water is great to drink, there's water that's kind of collecting and hanging out in that filter. And that's exactly where bugs like Pseudomonas and non-tuberculosis mycobacteria like to live. So really, like you do want to use like the sterile water or just distilled water. Sorry.
We have a comment that an induction burner, $80 on Amazon, will boil a pint of water in 20 seconds. So if you're looking for a fast, easy solution, that might work. Okay. I think we've talked about the albuterol before, hypertonic saline. somebody is concerned there that their sister was misdiagnosed with CF for 7 years and used Pulmozyme during some of that time. Is that going to have a bad impact on her bronchiectasis?
I would say everyone is really an individual, and I think it's unlikely. But your sister's an individual, and I would say like, so I'll be honest with you, I was very traumatized by the lack of Pulmozyme and bronchiectasis. So I actually emailed one of the authors about one of my patients saying that they had done well on Pulmozyme, and do I have to stop it to make this guideline, because I obviously don't want anything bad to happen to someone I'm taking care of. And their response was, if someone's really doing well on Pulmozyme, that was just one review of the literature and it doesn't apply. And if you look at the paper that I was talking about where they compared CF to PCD, the Pulmozyme piece was actually pretty controversial because there's a number of people that think that it is beneficial in PCD. But the other thing that I want to say is that life always has to move forward. And for many people with PCD, the diagnosis is long. So I would just encourage folks not to think that someone did something and now you're past the point of no return. You just might have to kind of change the approach and do something else. That's all.
So and I can tell you anecdotally, we hear from patients, some who think it works really well and they love it, and some who don't see any benefit from it at all. So it does look like, until we have more information, Pulmozyme especially is going to be one of those case-by-case basis things. It's an expensive drug. There's some suggestion that it might, and some people have worse outcomes. So it just is something that needs to be evaluated.
I think too, like Dr. Davis was talking about all the changes in asthma, and asthma has been really heavily researched for decades. And there was a recent paper about asthma that talks about all these subtypes of asthma. And I think when we think about diseases like PCD, cystic fibrosis, bronchiectasis, we, over time, as we understand the science better, we're going to get more and more specific. So there really probably is a subgroup of people, not based on a specific genotype, but a subgroup of people who the combination, the way that their PCD and the rest of their genes are interactive, they would really be responsive to Pulmozyme, and it would be a good choice for them. I don't know, Dr. Davis, if you have anything to add.
Yeah, no, I think that's spot on, and not to go again too far down a researchy rabbit hole here, but one of the things that to sort of echo, I think a common theme here is we need to get more PCD centers. We need to get more people collaborating. One of the things that really helped CF and some other airways diseases are that in the 1990s, there was enough of a consortium of people collecting secretions that people were able to actually look at CF secretions. This is where a lot of the Pulmozyme data came from. I don't know this just because my mentor was the one that did all of it, but and look at what drugs do what to CF sputum, and also look at the different CF sputum within patients. In CF, it tends to be very similar because CF's an issue with one protein. PCD is an issue with a lot, but we know that PCD sputum is very different from CF sputum. If you just look in the nose or the lungs of a person with PCD, and to date, no one's ever looked at the types of sputum in PCD because it hasn't been studied well enough. And I think that Dr. Collins earlier said, we're all individuals, personalized therapy is the future. I do think that a lot of these questions can be answered, and that things like these meetings, Beat PCD, the IPCD-PN, are the way we're going to get those answers, just like how we're going to get better at what airway clearance therapy is best for what patient.
I mean, I think it's important for patients to know that it's not that there's not interest in studying PCD. There's a lot of interest in studying PCD. There aren't enough patients. So we have to find them, and then we have to get patients to be willing to participate in these studies. That's the only way we'll get this information. Even globally, there's not enough patients to do the kind of studies that we need to be done. Even if we all got together globally, we still have some gaps there.
1000%. Yep.
Okay, question. Do carbocysteine and N-acetylcysteine work in the same way?
I want to say yes. I'm trying to remember what carbocysteine is. It's not well. Melanie, do you remember?
I think it's disulfide bonds.
Yeah. Yeah, it's the same.
Oh, it is
Yeah.
the same.
Yep. That both of them work by breaking down bonds. I want to say carbocisteine is just used internationally. I'm curious, the person who asked that question, are you in an area where people use carbocisteine? Are you willing to tell
I
us?
think it's more in Europe, right?
Yeah, that's what I thought.
The only thing I would say is N-acetylcysteine, even orally, is supposed to be generating a certain anti-inflammatory effect, and I can again write it on my list to double check because we're already looking up GlyNAC. I don't believe that carbocisteine has been studied in that same way.
Yeah, that's what I was gonna, if you don't mind me piggybacking on that statement. So that's a thing that's important because it seems like this audience knows both uses. When people inhale N-acetylcysteine, it is actually for an entirely different reason, most of the time than when people ingest it. And so, as Dr. Collins said, it's an anti-inflammatory, antioxidant. But it also has properties that break down mucus. But what's important to say about that is that all of those properties were studied on mucus outside of the body. So if somebody coughs up mucus and we test drugs on it, this is true for most of the other over-the-counter drugs that we talk about. And it's a very different thing from saying this breaks down mucus from saying that will A, break it down to something that's easier to cough up or clear out, and B, that it doesn't have bad effects on the airways. And I think I saw a question or a comment earlier that was similar to this. Well, why do we not use hypertonic saline if we know that it hydrates mucus? Why do we not use Dornase if we know that it breaks down mucus? And the real answer is that not all mucus is the same, but also that just because it does these things in a petri dish doesn't mean that it helps us clear that mucus out. And I think that's for me a thing I'm always trying to tell my patients is it's not just about breaking it down or making it thicker. It's about getting it out of your airways without harming your airways to make your airways better.
Yep, and mucomys can cause bronchospasm, which
Yep.
is another important thing. We're talking about like pills and things, and I do just want to take a moment to say that anything you inhale or put in your nebulizer should come out of a sterile vial that you've broken, that you've just put in there for that day, and that is designed to be inhaled because it should be at a certain pH for your lung. And there are plenty of scenarios where if you inhale a contaminated solution, you are really, you're at a very high risk to get an infection. It's almost guaranteed. So I would just really encourage you to only use things that you've picked up from your pharmacy, that you're opening the vials yourself.
The person who asked about the carbocisteine did send a note saying they're from the UK.
Yes, it is exciting. It's an exciting idea that you would take a pill and it would help break up your phlegm.
So this is an interesting question about neutrophilic inflammation. What are the signs? We just had this discussion about in bronchiectasis, all patients with bronchiectasis have neutrophilic inflammation. They may also have eosinophilic inflammation, but they all have neutrophilic. What if you don't yet have bronchiectasis? What would be the signs that you have neutrophilic inflammation that may benefit from drugs that are directed at that? Like a child with a new diagnosis, PCD.
Well, I think everyone has neutrophilic inflammation because of the fact that we're retaining mucus, and the bronchiectasis is just as a sign that it was existing. And I think when you get bronchiectasis, again, depends on other genetic factors, but it also depends on what you're exposed to. And so my belief is that the more you're kind of clearing the mucus and not allowing those neutrophils to dwell on the surface of the mucus and all of those chemical byproducts, the more you're cleaning it out, the less likely you would have damage. In research studies, you can do a bronchoalveolar lavage and look at the neutrophil elastase to see if it's elevated or not. But that's just one day, so you can't really be assured that it's true. So based on the pathophysiology of PCD, I would assume there's always an element of neutrophilic inflammation.
Okay, Question about, we're running out of time again. We're coming up on the hour. A person who does have asthma and PCD and has trouble coughing up sputum. And this is a good question for me because I know we always hear, oh, people with PCD have no trouble coughing up sputum. That is not actually true. Some people do. And does this make a difference? If you have that sort of a phenotype, you also have asthma, would that change what you do for airway clearance therapy? For PCD?
For PCD. So I have to be honest with you, we are a huge airway clearance center. So if I have an asthmatic with a junky cough, I am also using airway clearance for that too. I don't know, Dr. Davis, if that
makes me very happy. I love
just
hearing
have
that.
mucus. You have to clear the mucus. I would say too, we focus on cough. Cough is very important. Huff cough is very important. But one of the nice things about the active cycle breathing technique is really getting this awareness of what your body feels like. And you can, even if you don't have a ton of mucus, you can start to feel things moving around and getting that appreciative feeling of this is clean and this is not clean. In our clinic, we use a lot of aerobica for our asthmatics because it's quick, simple, easy to use. And if they're having an exacerbation, they can just inline their albuterol or their albuterol and ipratropium. So I think that would be my recommendation. And as long as your lung function is looking good, it's not necessarily required that you physically cough out this much mucus every single day. But the fact that you don't cough and you don't have anything to cough up doesn't mean that there's nothing there and doesn't mean that the airway clearance isn't being beneficial. I don't know if Dr. Davis had anything
No, I
else.
think that's spot on. Yeah. And I would just emphasize this is in no way challenging who your pulmonologists are, but a thing to remember is that just because it's a very different disease and it's often more mild, asthma is also just as complicated and can require real specialty management, almost as such as PCD. And so just because you have PCD and asthma, I wouldn't necessarily, I would just be mindful that both of those diseases require really coordinated diagnosis and care.
And they feed off each other, right?
Right.
So
and they feed off
the
of each
chemical,
other.
we think about the chemical mediators for asthma, we think about the chemical mediators for PCD, but unfortunately they talk to each other. So when your asthma is out of control, it's going to drive inflammation in your PCD, and your PCD is going to drive inflammation in your asthma, and it just kind of swirls around in that vortex that Dr. Sanders showed, like Dr. Davis was mentioning before.
1000%. Yeah.
Okay, so I think we're probably going to have to close up shop here, but I think the key messages are airway clearance every day is important. Have a menu of options. Don't stick to just one. We have some ideas now just from questions for future webinars. I think we need one showing active cycle of breathing and how to do it, that technique, so people get comfortable with it. We had just have a comment about progesterone levels right before periods, and the whole issue of lung disease and women's hormones that should be a webinar on its own because it's a big topic. So we will address that. Quickly for Joy, who asked about participating in studies. Yes, I know it's challenging when there's nothing close. However, we are looking at more and more at doing remote studies so that everyone can participate, and you'll be hearing more about that. And for anybody that I missed, I am
So
sorry.
for remote studies, we're actually working on Spanish and English videos of active cycle breathing technique because we find it's really tricky for people to see. So if you would like to review our videos before we finalize them, please just send an email to the PCD Foundation and we will add you to our list because making a bunch of videos that no one understands but me and my med student is not going to be very efficacious. But
All right. Thank you, everybody. Sorry for anybody we missed, but we'll be back in touch. Thanks again.
Thank you all.
thank you.